Hello guys, today is the third session of our endocrinology series. In today's session, we are going to talk about the thyroid gland. In this session, we are going to take a basic introduction about the thyroid gland, and in the second part, we are going to talk about the physiological functions of thyroid hormone, and in the third part, we are going to talk about the regulation of thyroid hormone secretion. The first part, introduction to the thyroid gland. Thyroid gland is one of the largest endocrine glands. It is about 50 to 20 grams in adults and it is located below larynx. It is anterior to trachea and the thyroid gland has a very rich blood supply. It gets about 5 times more than the gland weight. And the major role of the thyroid gland is regulation of metabolism, growth and the development. What are the hormones of the thyroid gland? Thyroid gland secrete three main hormones. They are thyroxine, T4, triiodothyronine, T3, and the calcitonin. The thyroxine, T4, it is about 93% of secreted hormone and it is long acting but it has a weaker potency. Triiodothyronine, T3, it is about 70% and it's more potent and it has a fast action. The calcitonin regulates the calcium metabolism. The secretion of calcium is controlled via the TSH, which is secreted by the anterior pituitary. What are the physiological effects of T3 and T4? Regarding the metabolism, then there is a deficiency of thyroid hormone. Like in hypothyroidism conditions, the basal metabolic rate drops about 40 to 50%. And in contrast, if there is excess, like in hyperthyroidism, basal metabolic rate is increased about 60 to 100%. In growth and development, thyroid hormones are essential for normal growth and brain maturation. When we talk about the potency, T3 has more potency than T4. T4 serves mainly as a prohormone and it is converted to T3 tissues. The thyroid gland structure. Thyroid gland is composed of spherical follicles. These follicles are lined by cuboidal epithelial cells. These epithelial cells are filled with colloid. This colloid contains the thyroglobulin. The thyroglobulin is a large glycoprotein and it stores thyroid hormones until they are needed. The importance of thyroid. Importance of iodine. Iodine is essential for synthesis of thyroid hormone T3 and T4. The daily requirement of iodine is about 1 milligram per week. When we have iodine deficiency, we can get goiter or hypothyroidism. So to prevent that iodine deficiency, there is iodized salt. Sodium iodide is added to sodium chloride. The iodide transport or the iodide trapping. In the basolateral membrane, there is a sodium iodide symporter. This pumps iodide into the thyroid cell. So it gets the energy from sodium potassium ATPase. There is a concentrate gradient. Okay. At the apical membrane, the iodide is transported in the follicle by pendrite. So what are the steps in hormone synthesis? The thyroglobulin is secreted, which is contained the thyroxine residues. So when the oxidation of iodide happens and the iodine is produced. So the enzyme which helps for this process is thyroid peroxidase and it requires hydrogen peroxide. When the organification happens, iodine binds to tyrosine and it produces MIT and DIT. So these coupling reactions help to produce T4 and T3. Storage in the follicles. Hormones remain attached to thyroglobulin in the colony. Each thyroglobulin molecule attaches up to 30 to 40 molecules. And there is a unique feature. Thyroid can store hormone for 2 to 3 months. And the clinical point is, as it stores about hormone for 2 to 3 months, when there is a deficiency, it takes about months to appear the deficiency. Release of hormones into the blood. The colloid is reabsorbed into cell via endocytosis. So the lysosome fuse with vesicles and the proteases release T3 and T4. So the hormone is diffused into capillaries. And if the MIT and DIT not secreted, deiodinase recycles the iodine. So daily secretion pattern. About 93% of daily secreted hormone is T4 and the 7% is T3 in the tissues. 50% of T4 is converted to T3 and the effective daily delivery is about 35 T3 tissues. How the thyroid hormones are transported in the blood. The thyroid hormones 99% is bound to plasma proteins like thyroxine binding globulin, prealbumin and albumin. Three hormones are the active forms. In the blood, the half-life of T4 is about 6 days and T3 is about 1 day. It's the onset and duration of action. The tyrosine T4, it has a slow onset, about 2 to 3 days latency, and the peak effect is at 10 to 12 days, and the effects last weeks. Their half-life is about 15 days. The T3, it has a fast onset, like 6 to 12 hours latency, and the peak effect is we can get it within 2 to 3 days, but the effect lasts a shorter duration. Thyroid session, we are going to talk about the physiological functions of thyroid hormone. This is an illustration of the physiological function of thyroid hormone. In future slides, we are going to talk more discretely about these functions. So the thyroid hormones increase transcription of large number of genes. The result is there is increased synthesis of proteins like enzymes, structured proteins and transport protein. So this causes a generalized increase in functional activity in almost all cells. So the thyroid hormones increase the functional activity in almost all cells. It affects the whole body. T4 was T3. The most secreted hormone is the T4, thyroxine. In tissues, T4, thyroxine is converted to T3, thyroidothyronine. But the T3 is the active form and more than 90% of T3 binds to receptors. The nuclear action of thyroid hormones. Thyroid hormone receptors are located on DNA or nearby. So this binding activates the transcription. So it increases mRNA synthesis and it increases the protein synthesis. But not all the protein increase in same amount. Some are slight and some are in more amount. Non-genomic effects. So the rapid actions. It has a rapid action and it is independent of gene transcription. The sites are the plasma membrane, cytoplasm and mitochondria. So the effect is it regulates the ion channels and oxidative phosphorylation. So this action is mediated by second messengers. What are the metabolic effects of thyroid hormone? As we talk in first part, the thyroid hormone increases the basal metabolic rate by 60 to 100%. And it increased the food utilization for energy. It also increased the protein synthesis and catabolism. The thyroid hormone increased the growth rate in the youth and it increased activity of other endocrine glands. Mitochondria. Thyroid hormone increased number and size of mitochondria and it also increased the surface area of mitochondrial membrane. And this is directly linked with increased ATP production and energy supply. Ion transport. So the thyroid hormone increases sodium potassium ATPase activity. So the result is there is increased sodium and potassium transport. So the cell membranes leaky to sodium plus. So the more pumping is required. So energy use is increased and increased heat production happens. What are the growth effects of thyroid hormone? Thyroid hormones are essential for normal growth in children. When there is a deficiency in thyroid hormones, like in hypothyroidism, there is growth retardation. When there is increase of thyroid hormone, like in hypothyroidism, there is rapid skeletal growth, but early epiphyseal closure happens. And thyroid hormones are critical for brain development in fetus and early childhood. So when there is a deficiency at birth, it can cause cretinism. If it is untreated, the condition is irreversible. The carbohydrate metabolism. Thyroid hormone increase the glucose uptake by cells and increase glycolysis and gluconeogenesis. It increase GI glucose absorption, and also as secondary effect, it increase the insulin secretion. Fat metabolism. Thyroid hormone mobilize fat from tissues, so it deplete the fat store. So the plasma free fatty acids increase, and there is increased fat oxidation. And also it decrease the plasma cholesterol, phospholipid and triglyceride. And it increase the LDL receptor activity in liver. So in hypothyroidism, there is increased plasma cholesterol. So the hypothyroidism patients are risk of atherosclerosis. The vitamin requirement. When there is increased enzyme production, there is increased need for vitamins. So increased coenzymes. So excess thyroid hormone. In hypothyroidism conditions, patients may suffer from vitamin deficiencies. BMR and weight. In hypothyroidism, as we talked previously, basal metabolic rate increase about 60 to 100%. So there is weight loss. Though the patient have increased appetite, he or she may have weight loss. And in hypothyroidism, contrast to that, basal metabolic rate decreases and patient may have weight gain. The cardiovascular effects. There is increased tissue metabolism. So vasodilation happens and increased blood flow. In hyperthyroidism condition, there is increased cardiac output. Up to 60% above is normal. So as a direct excitatory effect, there is increased heart rate. In mild thyroid hormone increase, there is stronger heart contraction. But when there is excess thyroid hormone increase, it can cause cardiac weakness and failures. But in this condition, arterial pressure usually normal, but pulse pressure can be widened. The respiratory effects. Thyroid hormone increase oxygen use and carbon dioxide production. So this stimulates ventilation. Increased rate and depth of respiration happens. Gastrointestinal system. Thyroid hormones increase appetite, food intake, digestion, juice secretion. So it also increases gastrointestinal tract mobility. So in hypothyroidism, patient may get diarrhea, and in hypothyroidism, patient can get constipation. CNS effect. In hypothyroidism, patient may be anxious, nervous, irritable and psychosis can happen. In hypothyroidism, there is mental sluggishness, slow cerebration. In muscular system, when there is mild increase in thyroid hormones, muscles may become vigorous. In excess thyroid hormone increase, muscle weakness can happen due to catabolism. In hypothyroidism, there is sluggish muscles, delayed relaxation. In hyperthyroidism, there can be fine tremors. Sleep. In hyperthyroidism, patient may suffer from insomnia, excess excitability. In hypothyroidism, there is somnolence, prolonged sleep. Endocrine interactions of thyroid hormones. As thyroid hormone increase glucose metabolism, it also increase the insulin requirement of the body, and it also increase bone metabolism. So there is increased need for PTH, and it increase the inactivation of glucocorticoid. So the feedback increase the ACTH secretion and there is increased cortisol secretion. The sexual function in men. When men have hypothyroidism, they can have decreased libido. In hypothyroidism, sometimes they have impotence. Women, when suffer from hypothyroidism, they can have menorrhagia, irregular cycle, decreased libido. In hypothyroidism, women can suffer from oligomenorrhea, sometimes amenorrhea. The mechanisms are combination of metabolic and pituitary feedback effects. Third part of the thyroid session, we are going to talk about the regulation of thyroid hormone secretion. This is controlled by hypothalamus pituitary thyroid axis, and this helps to maintain stable levels of thyroid hormone for metabolism and growth. The role of TSH, thyroid stimulating hormone. It is secreted by the anterior pituitary. This is a glycoprotein. The main effects of thyroid gland by TSH is it increases the proteolysis of steroid stored thyroglobulin, and this helps to release T3 and T4, and it also helps to increase iodide trapping by iodide pump, and it increases the iodination of tyrosine. This helps to create the thyroid hormone, and TSH also increase size and activity of thyroid cells. So it causes hyperplasia of cuboidal cells to columnar cells and epithelial infolds. Timing of TSH effect. The effect is early effect within 30 minutes. It can cause proteolysis of thyroglobulin and it causes the releasing of thyroid hormone. The late effects, which takes about hours to days, cause increased iodide transport, hormone synthesis and thyroid growth. The mechanism of TSH action. TSH binds to TSH receptors on thyroid cell membrane. This activates adenyl cyclase. So it increases the CAMP and this CAMP activates protein kinase. This activates the phosphorylation cascade. So this action results in increased secretion and growth of thyroid gland. The role of TRH, thyrotropin releasing hormone. This is secreted by median eminence of the hypothalamus. This is transported via hypothalamic hypophyseal portal system. So this hormone directly stimulates anterior pituitary to increase the TSH secretion. Mechanism of TRH action. The TRH binds TRH receptors on the pituitary thyrotropes. So this activates phospholipase C pathway. So it increases DAG, IP3 and calcium. So this causes the exocytosis of TSH. The effect of cold on TRH and TSH. Cold exposure stimulates hypothalamic thermoregulation centers. So this increases TRH, it increases the TSH. So the effect is increased thyroid hormones. Increased thyroid hormones means there is increased metabolic heat production. So the adaptation is basal metabolic rate is increased to 40 to 20% in prolonged cold. The effect of stress and emotions. Excitement, anxiety activates sympathetic nervous system. So it decreases TRH and TSH secretion. This is an inverse effect due to heat production. So the effect lost if pituitary stalk is cut. So it confirms the hypothalamic control. Negative feedback control. Increased thyroid hormone levels inhibit anterior pituitary secretion of TSH. This is a direct feedback effect on pituitary. And this is the main mechanism. So this negative feedback control helps to maintain constant free T3 and T4 levels in the blood. Antithyroid substance overview. The drugs and chemicals that suppress thyroid hormone secretion. They are important in clinical management of hypothyroidism. Example, thiocyanate, propylthiouracil, high-dose iodide. Thiocyanate. This complete with iodide for iodide pump. So it decreases the iodide trapping. thyroglobulin is still formed in this mechanism but not iodinated. So this leads to decreased hormone production and decreased compensated. It leads to compensated increase of TSH, and it is used in goiters. Propiothyroxine. This inhibits thyroid peroxidase enzyme. So this blocks iodination of tyrosine. So this PTU blocks coupling of MIT and DIT. So the effect is decreased synthesis of T3 and T4. So when the feedback is there, it increases the TSH. So we can use that for thyroid enlargement. High dose iodide. Plasma iodide is increased 100 normal, but it is normal, but it suppresses the thyroid function. So it decreases iodide trapping, decreases iodization of tyrosine. So this blocks endocytosis colloid. So this effect is immediate decrease of hormone release. The clinical use of iodide. The effect of iodide is temporary. It is about 2 to 3 weeks only, and it decreases thyroid size and blood supply. So this effect is temporary. So this use before thyroid surgery. So it decreases the bleeding and gland size. So that's the end of our thyroid session. Thank you.